Obesity, a preventable disease that can exacerbate type 2 diabetes. Obesity is a typical yet frequently belittled state of clinical and general well-being significance in numerous nations around the globe. Its overall acknowledgement by numerous social orders as an indication of prosperity or an image of high societal position, and the denial by healthcare professionals and the public alike that it is an illness in its own right, have added to its inappropriate identification and the management and the absence of successful general well-being procedures to battle its ascent to pestilence extents. If you are watching this video for the first time, please kindly like this video, hit the subscribe button and click on the bell icon so that any time I make a video like this, you will be notified. Obesity is characterized as a state of unusual or exorbitant fat gathering in fat tissue, to the degree that well-being is impaired. The measure of abundance fat in total terms, and its distribution in the body, either around the waist and trunk, abdominal, central or android obesity, or peripherally around the body, gynoid obesity, have significant well-being suggestions. In general, obesity is associated with a great danger of becoming handicapped or unexpected death because of type 2 diabetes mellitus (T2DM) and cardiovascular sicknesses (CVD), for example, hypertension, stroke and coronary illness, just as nerve bladder ailment, certain cancers, endometrial, breast, prostate, colon, and non-fatal conditions including gout, respiratory conditions, gastroesophageal reflux disease, osteoarthritis and infertility. Obesity likewise conveys serious implications for psychosocial well-being, for the most part because of cultural partiality against fatness. A central distribution of body fat is associated with a higher danger of morbidity and mortality than a more peripheral distribution. Besides, people with CVD hazard factors, for example, T2DM, hypertension and smoking, are exposed to significant health risks at lower levels of obesity. It is hence imperative to assess people who are overweight or obese not exclusively to decide the degree of adiposity, but also for the body fat distribution and the presence of comorbid factors. The body mass index (BMI) is a simple and commonly used parameter for classifying various degrees of adiposity. It is derived from the weight of the individual in kilograms divided by the square of the height in meters kilogram per square meter. By the current World Health Organization (WHO) criteria, a BMI less than 18.5 kilograms per square meter is considered underweight, 18.5 to 24.9 kilograms per square meter ideal weight, and 25 to 29.9 kilograms per square meter overweight or pre-obese. The obese category is subdivided into obese class 1 30 to 34.9 kilograms per square meter, obese class 2 35 to 39.9 kilograms per square meter, and obese class 3 is greater than or equal to 40 kilograms per square meter. A BMI greater than 28 kilograms per square meter in adults is associated with a 3 to 4-fold greater risk of morbidity due to T2DM and CVDs than in the general population. Measurement of the waist circumference, measured at the midpoint between the lower border of the rib cage and the iliac crest or the waist-hip ratio (WHR), provide useful indices of abdominal fat accumulation and a better correlation with an increased risk of ill health and mortality than BMI alone. An abdominal girth in excess of 108 cm 40 inches for men and 98 cm 35 inches for women, or a WHR greater than 1.0 and 0.85 in men and women, respectively, are the currently accepted indicators of excessive abdominal fat accumulation, which correlate with a substantially increased risk of metabolic complications. In spite of specific restrictions with its utilization, there is general concurrence with the relevance of BMI estimations for evaluating underweight, overweight and obesity in grown-ups. The case for kids and young people is, notwithstanding, unique on the grounds that unlike adults, BMI changes fundamentally with age during these phases of development. In the last part of the 1970s, WHO suggested the utilization of a development reference for small kids created by the United States National Center for Health Statistics. The information from which this reference was inferred is currently old and, in view of kids from just the USA, can't practically be applied to all populaces around the world. The WHO has as of late supplanted this reference with another one which draws information from a network-based, multi-country investigation of babies and little youngsters from birth to 6 years in the entirety of the world's significant areas, including developed and developing countries. Ghana was one of the 6 participating countries in the new study. What is currently anticipated is a comparative worldwide development reference for more established kids and teenagers. Up to that point, age and gender explicit BMI charts derived from data sets from 6 distinctive reference populaces Brazil, Great Britain, Hong Kong, the Netherlands, Singapore and the USA could be utilized. Causes. There is presently a global epidemic of obesity in all age groups and in both developed and developing nations. In 1995, there were an expected 200 million obese adults around the world. Starting at 2000, the number of obese adults had increased to more than 300 million. In developing nations, it is evaluated that more than 115 million individuals experience the ill effects of obesity-related issues. A quick increment in childhood obesity has likewise been accounted for. From an enormous group of proof, the worldwide epidemic of obesity has come about for the most part from cultural elements that advance inactive ways of life and the utilization of high-fat, energy-dense diets. While genes are significant in the assurance of an individual's susceptibility to weight gain, obesity, all things considered, happens when energy intake based on what is eaten and drank surpasses energy use over an extended period. Fat kids are almost certain than their non-obese partners to develop into obese adults. Information from various investigations likewise gives strong proof that youngsters who are growth retarded during childbirth have an increased danger of getting fat in later life. This marvel, which infers fetal programming of adult obesity, is especially prone to happen when a low body weight during childbirth from intrauterine development hindrance (IUGR) is made up for by a catch-up growth in later life, and when this adiposity bounce back happens early in childhood. Inconsistently, weight might be a sign of other ailments, for example, hypothyroidism, Cushing's condition and certain hypothalamic issues, which ought to however much as could reasonably be expected be prohibited on clinical grounds and sometimes by lab examinations before continuing to oversee patients. Expanded insulin discharge is a typical outcome of obesity. The conjunction of hyperinsulinemia with typical or raised blood glucose levels in obese people recommends the nearness of insulin opposition, presently all around acknowledged as the regular hidden instrument for various infection states including T2DM, hypertension, dyslipidemia and cardiovascular maladies. The conglomeration of a few of these cardiovascular ailment chance elements, including weight, in a similar patient shows the nearness of the metabolic condition which has noteworthy ramifications for cardiovascular well-being. Weight reduction strategies. Weight reduction and support systems incorporate dietary treatment, physical movement, way of life adjustment, conduct treatment, pharmacotherapy and every so often medical procedure. Utilizing these methods, the objectives are, in any event, to forestall further weight gain, or accomplish weight decrease and keep up the lower body weight over a long term. A few master boards have proposed the best strategies for evaluating and treating obesity. Right now, weight reduction treatment is suggested for patients with a BMI is greater than or equal to 30 kg per square meter and those with a BMI somewhere in the range of 25 and 29.9 kg per square meter or a high-risk waist circumference who have 2 or more cardiovascular risk factors. Treatment must be outfitted to a 10% body weight decrease over a 6-month time frame, at a pace of 0.5 to 1 kg for each week, 2 to 4 kg for every month. Dietary therapy should ensure an intake reduced by 500 to 1,000 kilocalories per day from the current level. Low-calorie diets (LCDs) containing 1,000 to 1,200 kilocalories per day for most women and between 1,200 kilocalories per day and 1,600 kilocalories per day for men can result in sufficient weight reduction. Very low-calorie diets (VLCDs) containing less than 800 kilocalories per day are no more effective than LCDs in producing weight loss and are to be discouraged. Physical activity increases energy expenditure and also reduces the risk of heart disease more than that achieved by weight loss alone. Physical activity, walking, dancing, gardening, household chores and team or individual sports should be increased slowly to a level that ensures at least 30 minutes or more of moderate intensity physical activity on most, and preferably all, days of the week. Behavioral strategies including self-monitoring, stress management and social support can enhance the gains from dietary methods and physical activity. Drug therapy should be used only in conjunction with diet, physical activity changes, and behavior therapy and only when these measures have failed to promote weight loss after 6 months. Orlistat, an oral pancreatic lipase inhibitor which inhibits the absorption of 30% of ingested fat from the intestine, is currently the only drug approved by the Ghana Food and Drugs Board for long-term treatment of obesity. Its side effects may include abdominal pain, flatulence and oily stools following a meal containing fat. Weight loss surgery, using various techniques, is an option only for well-informed and motivated patients who have clinically severe obesity. BMI is greater than or equal to 40 kg per square meter, or a BMI is greater than or equal to 35 kg per square meter accompanied by serious comorbid conditions. Prevention is the key to controlling the obesity epidemic. For more information about how to best manage diabetes, I have left a link below. You might want to check it out. Thank you for watching.